Thank you. Thank you very much, Dr. Gubini and Dr. Franchini. That was very inspiring. We are now open for questions, so let us please welcome back our panelists, Dr. Sito Morang, Dr. Connor, Prof. Lee, Dr. Gubini, and Dr. Franchini to join us for the Q&A. To the audience, and since we only have 20 minutes, please type in all your questions. So we want to answer all of your questions as much as possible. Please type them in the Q&A box. Okay, so I think Dr. Relly, would you like to start with the first question?
Okay, thank you, Dr. Regina. First question is from Sungwi Huang from the Q&A box. The question is it antibiotic prophylaxis given routinely for this office hysteroscopy procedure? Especially in the case unless there may be tubal block or underneath hydrosalpinx. Maybe one of the panelists can answer it. Is it necessary to give the antibiotic prophylaxis? Or maybe from Dr. Connor? Yeah.
Hello. We do not give antibiotics on a routine basis, but if there is evidence of a hydrosalpinx, then it's worth considering. It's not impossible for infection to occur. The VAST study that I mentioned in my talk showed an rate of infection of between 1% and 4%. Now, it was a very broad definition of infection, but just the occasional acute infection can arise, and it's clearly very important in this particular group of patients that you avoid it. So if you do have any worries about hydrosalpinx, and you'll have checked these patients already for sexually transmitted infections, then a broad spectrum of antibiotics or coamoxiclav would be appropriate to give immediately beforehand. But as a routine, no. I'll be interested to hear what the others say.
Yeah,
Professor.
I would fully agree with Ms. Connor. This is what I would do. I don't routinely give it, but in case of people having a tubal pathology diagnosed on the spot, then it's a good idea to give some form of antibiotic.
Okay. How about for the antiseptic liquid? You give routinely to give antiseptic inside the vagina before from hysteroscopy office?
I do it just
not used to. Oops, sorry.
Please, Mario.
Please.
Sorry. Yeah, in my daily practice, I use the antiseptic only for the surface, and we cover it also with the sterile sterile blanket, just to avoid any unsterile surfaces during the procedure.
You never put antiseptic intravagina?
No. Just the surface.
Now is more or less 25 years that we are using vaginoscopic approach, using saline. So from that time until now, we never use any antiseptic, not at all. So I don't know if it's the same everywhere, I think now. And there is no need to perform antibiotic treatment, perioperative antibiotic treatment. So all the guidelines are telling us that this kind of approach procedure is safe enough. So we can avoid any treatment, any antiseptic approach.
Okay, thank you, Dr. Mario. The next question, I think anyone can answer. No? Can saline sonogram with 3D transvaginal ultrasound be good enough to assess any endometrial pathology short of performing hysteroscopy? I think Dr. Herbert, you can answer this one.
Okay, so the question is whether or not we can use the ultrasound guided during polypectomy with the NC without using the hysteroscope. To my view, doing a blind procedures, even though we guide it with ultrasound, but sometimes we miss in which surface that the polyps located. Is it in the anterior, in the fundus, or in the posterior? By doing that, we have some chances of leaving some part of the polyps inside, and there is also chances to injure the healthy tissue, healthy endometrial tissue. So I think the best one is still the hysteroscopy, where we can see directly the polyps and whether or not it's complete or not. And of course, we need to do it completely by making sure with the view. So I think the one of the important constraint of using the hysteroscopy, the only one is the cost. One of the most important one. If we can lower the cost to a proper cost, I think hysteroscopy is the best approach for intrauterine problems. That's my opinion.
Thank you, Dr. Herbert.
Yeah, Dr. Herbert.
Yes.
How about for the saline sonogram with the 3D transvaginal ultrasound? Do you have experience to use 3D with saline infusion?
For diagnostic, it's fantastic for diagnostic, right? But we need to directly manage the intracavitary pathologies. That's only by hysteroscopy that we have the capacity of see and treat capacity.
Because usually we have saline infusion sonography with 2D ultrasound transvagina. But how about for the 3D ultrasound on saline infusion sonography? I don't have any experience for that.
It gives you better mapping of the pathology, but I think most of the time 2D is enough because we can swipe all the surface of the cavity, and we don't need 3D in that kind of case, in my opinion.
Yeah. For another panelist,
yes,
Lee or Dr. Khanna, do you have any experience to perform ultrasound 3D dimension for saline infusion sonography? Yeah.
Yes, Prof.
Yeah, I think I would agree with Herbert that in most cases, it is probably not necessary to use 3D. Routine ultrasound 2D should be enough, but there are some circumstances where 3D will be particularly useful. For example, when you're thinking whether it's a small septum or whether it's arcuate uterus, then a 3D would give you a better definition. Or if you're looking at side wall pathology like submucosal fibroid, sometimes depending on the location, a 2D may not give such a sort of high definition, especially when you combine with a saline sonography. A 3D saline sonography could give you sometimes an advantage. Certain amount of side wall adhesion is the same. You can measure the width, but you can't do that in a 2D because you can measure only the anterior posterior diameter accurately. So agree, 2D most cases, 3D in selected cases.
Thank you, Prof. We have a question here for Prof. Lee. Is there a place for anti-adhesive barrier agent after release of adhesion?
Thank you for the question. I presume that question is more about, for example, hyalurobarrier gel. I think the earlier data suggests that it does work, and some meta-analysis also suggests that it does work in preventing primary formation of intrauterine adhesion, for example, after DNC. But I think a more recent data, a randomized controlled trial from Beijing, suggests that as a secondary prevention, hyalurobarrier might not necessarily be so effective. So I think we need more data about it, and we mustn't mix up the impact of a primary prevention versus secondary prevention. So I honestly think we need more data in that area.
I have another question for you, Prof. I was amazed with your balloon therapy. I remember it was being presented last time at that Aspire Congress. Question is, do you do the balloon therapy and second look for all patients post-Asherman syndrome treatment? And how often do you encounter de novo adhesion formation?
Okay, well, again, a very good question. I have to say, the balloon therapy, I don't do it routinely at second look. If at the time of second look, I know there's not much adhesion in there, or none at all, or minimal, then perhaps there's no need to do the balloon therapy, especially if I have already divided the adhesions. So as a means to treating adhesions, as a means to treat treatment, if there are quite a lot of adhesions that I can't see my way and I can pass the catheter, so it will be good for treatment, removing adhesions. But for prevention, there are two strategies. One is an intermittent approach, which is the one that I just showed you, putting it in, dilate it, and then taking it out. And the second approach is a continuous balloon therapy, where you put it in, you leave it for 10 to 14 days. During the time the endometrium is healing, if you don't have a balloon, you might stuck together. But when you have a balloon, you separate the two surfaces, and that could do a good job. But that needs to be 14 days or so. I put it in only if there are quite significant adhesions. If there's only minimal, very mild adhesions, then I don't routinely put in a balloon after primary adhesiolysis procedure.
Okay.
So I hope that answers your question, Regina.
Thank you, Prof.
Mario.
Yeah.
Yes.
As we are talking about hysteroscopy, I think that the best approach is using steel cold scissor to treat synechia and to perform adhesiolysis. And we are used, and my friend Gian Pietro is still doing the same than me, is to have a second hysteroscopic look after 1 or 2 months later. In that way, we can have a good reevaluation of uterine cavity, and we can perform if there is still something to treat at the same time. So at the moment in Italy, there are 2 groups performing hysteroscopy or using gel after. So we have to keep all the data and reevaluate these 2 different kind of approaches.
Thank you, Dr. Mario.
I agree. I agree. I think a second look is good, especially if a second look, you're using it in conjunction with a hydraulic knife, invisible knife. So when you see mild adhesion reforming, especially when they're green, when they're young, you can use the water to separate them readily. So a second look, perfectly agree. As for which modality of energy is the best, in general, I would agree that the least invasive, the least likely to destroy tissue is the best. So for myself, I think I would use the invisible knife as a first choice. It's very gentle. Then followed by scissors, and followed by diathermy. I know there are people who are concerned about diathermy because it might destroy, damage the already remaining bit of endometrial tissue. I think to use diathermy, one has to use it carefully. Though there are sometimes when there's so dense adhesions, very dense, and that you might have to do it as no choice. So we need more data about whether or not diathermy does indeed damage endometrial tissue in a significant way. But my preference is like Mario, like you say, I like to use the cold steel a little bit more so than diathermy. That's my instinct. But I sometimes use the diathermy. I know sometimes when there's too much, and you have to get on and do it. And there are times that you need, especially sidewall adhesions.
Thank you, Prof. There's another question here regarding Asherman syndrome. What about using intrauterine device to prevent intrauterine adhesions after treatment? So perhaps Prof can answer, or anyone else wants after Prof.
The intrauterine device is a rather more old-fashioned approach. I think it's been used for quite some years. The data, if you look at the data, look at the meta-analysis, there are hardly any good data to suggest that it works very well. But I know in the past, people don't have much technique. People know that to prevent adhesion, you need to separate the surfaces. But now there are better strategies like the balloon, or even like the gel that provides separation. I think the data regarding coil is not so strong. I myself personally, I have not used the coil, the intrauterine contraceptive device for quite some years. I think the last 10 years, I have basically stopped using it. So I use the balloon, I use the gel, I use second lobe, like Mario mentioned. So other strategies. I don't know what others are doing, but I'll be interested to know what other thing.
Yes, me too, Prof. Lee. So I did a second look as the best. I think that's the best prevention of the and also evaluation of our procedures. Yeah, I agree with you.
Thank you. I think we have time for one or two more questions. There's a question here. I think it's for anyone else. If there is severe bleeding using office hysteroscopy during the procedure, what is your what advice or what technique would you advise? Dr. Connor?
Hi, couple of techniques here. One is to have a dual flow system. So you'll need sometimes a slightly bigger telescope. You want an outflow, so you want to flush the cavity. The second thing to do is just slightly increase your intrauterine pressure, and that may be sufficient to stop the bleeding. You don't often encounter bleeding that's going to cause harm, but it's bleeding that's interfering with your view and what you're trying to see, what you're trying to do. So even the mechanical methods for removing polyps may give rise to a little bleeding, but it stops. It's not something you need to cauterize. So I think that's one of the clear differences between your electrosurgery and your mechanical means of removing tissue, such as scissors, graspers, the tissue removal systems. The bleeding is not a significant problem afterwards and will stop. And if you are concerned about it, then just keep an eye on the patient for a little while after the procedure, but generally it stops. You do not need to do anything, provided you know that they're not on the oral anticoagulants, but then they needed to have not taken those for a while beforehand. But that tends to be an older population rather than infertility patients.
Thank you, Dr. Connor. Yes, Dr. Mario?
It's just a consideration. If you have a big hemorrhage, probably there is or a mistake using loops, or you have made a wrong diagnosis. So you are treating what you have not to treat, like, for instance, placenta remnants, high vascularized. So the question is, be careful what we are planning to do, choosing the right pathology that they could be treated in an office setting or in a theater room using the correct instrumentation. So that is the problem. But usually, if you are working in the endometrial layer, it's practically impossible to have a so heavy hemorrhage. So be careful, because probably there is a mistake behind.
Thank you.
Regina, I got one more comment to make.
Yes, Prof.
Profuse bleeding. Yeah, I mean, Mario mentioned sometimes when you're removing product of conception, when they're quite deeply embedded, or sometimes after removing a fibroid, when you got a big vessel in the wall. Now, sometimes this bleeding can be very profuse. It could be quite frightening, and you can't stop them somehow, because when they're actively oozing, you can't see them well. You know the bleeding actively. I've come across a few cases of this, and I think for me, the best way to dealing with it is to check out the hysteroscope and put in the balloon. I know I'm a balloon fan, but I wanted to know the balloon is really very effective. You put in the balloon, inflate it with 5 or 10 mils of saline, tamponade. It works. When we are trained to do surgery, what is the best way to stop bleeding? Tamponade. Press on the vessel. Sometimes you might need to do a little bit, you might increase the pressure a little bit more, but especially under anesthetic, it would stop the bleeding almost immediately. Leave the balloon in for a few hours. For example, you need to put it in for 10 ml, 15 ml solution. 4 to 6 hours, you deflate by about half, and then gradually over ensuring 24 hours or 12 hours, then you can remove the balloon and observe it. But I found on several occasions, it really helps tremendously. So remember, when you got heavy bleeding, take out the balloon. It doesn't cost any money, just a Foley balloon, very inexpensive. And it works very, very impressively.
Thank you. Thank you so much, Prof. Unfortunately, we still have a lot of questions. I have a lot of questions, but the open forum has come to a close. So before I end this, is there anything else you want to add, Dr. Relly?
Okay, I think it's very nice discussion today. And thank you for all speakers has already shared their expertise to us, and maybe all the lecture can give our knowledge to improve our services to perform hysteroscopy. Thank you for.
Thank you. So thank you very much to all our panelists. I wish we had more time. So this was a very fruitful session. Thank you. Now I would like to turn the floor over to the hardworking president of the Philippine Society for Reproductive Medicine, Dr. Angela Aguilar. She will be moderating our next and final activity. Thank you.